Hey, good morning, everyone. Kathy Robinson here from NASEMSO headquarters. We're still seeing a few people logging in, but it's great to see all the participants that have joined us today. Welcome to the new ones, and thanks for coming back to the ones that participated yesterday. We had a very robust attendance. And so for a few announcements for this morning, first reminder that all sessions are being recorded. And I'll provide you a little bit of information how you will be able to access those. Today is National Emergency Nurses Day, so we want to take time to express our deepest appreciation for all the nurses working in EMS for their hard work that supports our greater good. All attendee lines are currently on mute. As we did yesterday, we will unmute all lines for interactions with presenters at the end of the sessions. We have established a new YouTube channel to share the videos of this week's recordings. The link is posted on our website, but it'll take a few days to edit and upload the recordings. All PowerPoint files are or will be available on the NASEMSO website under the information that we have posted there for NASEMSO Reimagined 2020. There is a revised agenda for today. The original session on rural EMS that was scheduled for 3 p.m. Eastern Time has been replaced with a presentation on NEMSIS. As an FYI, we are currently meeting in NASEMSO's Meeting Room A, and that link will remain in effect through the noon panel session tomorrow. Reinventing EMS is the noon session. Tomorrow's business meeting, however, will be held in the NASEMSO auditorium. We've posted a revised agenda in the handouts today, and we're also providing the information on the website for the login. This meeting is for rostered members. State roll call will be documented, and voting proxies must be communicated in advance to Beth Armstrong. The state directors networking session on Friday is by invitation only. We distributed the link by email at 4 p.m. Eastern Time on October 2nd if you want to look for that in your inbox. If you can't locate it and want to participate, you can contact Dia Gaynor for further guidance, including a heads up on topics that you need to discuss. The session that we are about to start is one that we have been looking forward to for a time because it's been coming up in some of our council meetings. So we're really pleased to be able to have this discussion today. As Dia mentioned a little bit earlier, we are trying to unmute all the microphones so that we can interact with the speakers at the end of the session, ask questions, those sorts of things. As we did yesterday, the chat box is available for your use, and you can raise your hand to ask a question if that is something that works better for you. So without further ado, I'd like to take this opportunity to introduce our special panel, a great group of folks that have been involved in NASEMSO for some period of time, talking to us today about remote inspections and surveys. We'll have Joe Schmieder will be starting the presentations on agency and ambulance inspections, followed by Carol Mays from MIMS talking about her experiences with trauma center designation. And then our partner from Illinois, Evelyn Lyons, works closely with EMSC and has been working with the inspections of pediatric emergency departments. So without further ado, Hannah, I think I sent you Joe's slides. If you can put them up on the screen, we'll go ahead and get started.
Good morning.
Hey, Joe, welcome. Thanks for joining us today.
It is my pleasure. And Kathy, just for logistics, will you be flipping or somebody will be flipping the slides for me?
Yeah, yes, just say next slide. Hannah has that covered. Thanks.
Okay, great. Well, thank you for this opportunity today, and for the people that are participating. Thank you for jumping on with us. This has been such a challenge across the board. You know, I was on a call yesterday, and I said to some people, you know, I've done some reading and reviewing of the 1918 pandemic. Really, in my belief, that Yeah, that was in 1918. You know, we had better food, better drugs, better communication, cleaner environment. It'll never happen again. And by the way, here we are now, and I've been sitting in my home now for 7 months, going to the office and to some meetings probably once a week or something like that. And the whole system has come more virtual. You know, on a side note, one of the things we're scheduled to move to a new building next June on the main campus of Department of State Health Services, and really the question is, what do we need? Because we are 100% virtual, meeting the work needs of our system, and it's been very successful. And I knew we were doing something right. We have a weekly statewide conference call back in probably April. They started out every day, then it was a couple times a week, and now it's once a week. And someone called in and complained because the state was doing virtual inspections and are doing CERs. I'm sorry, doing CERs. How can we do this? We're all under the gun and all this kind of stuff. Well, I knew we must be doing something right because now people are complaining that we're doing too much. So we've gotten there. We are there, and this process has worked really, really well. You can go to the next slide, Kath. Let me just do something here. There we go. So that's my contact information. You'll see it again more later on, and we'll just move on to the next slide. Maybe, there we go. So you know, this whole COVID responses, how do you meet the responsibilities of your job and have your team go out and make sure they're safe and meet the needs of the states that we're serving and the public that we're serving on a daily basis? And this has been a huge challenge. I mean, we have, I think we all have learned ways of doing things different than the way we were doing them before, but it's been very successful and been very helpful. And you can move on to the next slide. So one of the things in Texas, and we'll talk about the numbers, Texas is a big state, and it was really one of the reasons. Most of you probably know that I came here from Pennsylvania. I lived my whole life in Pennsylvania, and I think Kathy will confirm they didn't throw me out of Pennsylvania, but they were glad I was left. No. Yeah, my daughter and son moved to Texas, and now we have 3 grandchildren. And I will be whining like a little baby on Saturday because the temperature is going down to 50 degrees Saturday morning. I am used to the 100 degrees and I like the heat, but it's been a real pleasure and a real challenge to move to Texas. So we go to the next slide, Kath. And what really enticed me to come to Texas is just the size of Texas. When you look at our call volume, our dispatches, we do a EMS dispatch about every 10 seconds, or I'm sorry, every 6 seconds, and it's about 5.5 million calls a year, and that was kind of neat. And when you look at the size of Texas, keep in mind that if you're going from the north, right on the Oklahoma border, down to the border of Mexico, it's going to take you about 19 hours driving time. And when you go from El Paso, right by New Mexico, over to Louisiana, and I know I don't say it right, but a northern way of saying it, to the other side of Texas, it's about 19 hours. And one of the things, when I first got here, I drove around the state just to understand, and you know, you can travel all of Pennsylvania, north to south, east to west, in about 5 or 6 hours unless you hit a lot of traffic. But I have never been on an ambulance call where you get dispatched and you make it back 7 hours later, and that is very common in Texas, and especially the rural frontier area where you leave on a call and it may take you an hour to get there. And then if you're going to a trauma center or whatever, I looked at one, I was talking to one service yesterday, their level 1 trauma center is 167 miles from their building. So it is a unique system. You can go to the next slide, Kathy. So just to give you some of the numbers, we have 749 licensed EMS providers. That's agencies that most people would know, and then 584 first responders organizations, which are basically mostly fire-based. When I first got here 7 years ago, we had almost 1,300 EMS providers, but due to a lot of work being done by the state and by the federal government to clean up some of the Medicare fraud that was going on, I'll use Harris County as an example. Over by Houston, there was about 450 licensed EMS providers in that county, and today there's about 150. And we've cleaned up the system. And as I dealt with Medicare fraud in Pennsylvania, it was very similar going on here in Texas. Next slide, please. So licensed personnel-wise, we are just approaching, we're at 69,000 certified licensed people today. Since February, we've added 1,153 new people. Now, taking into consideration that number is higher than that because we've lost and we've gained. So people, we certify, there are people who come up for a renewal every month. So some of those people may have dropped off and choose not to recertify, but we're ahead of the game of the total number of people by 1,153. Next slide, please. So what do we inspect? We inspect EMS providers, that's agency, that's licensed ambulance companies, which consists of ground and air ambulances, as well as specialized vehicles. There's about 5,000 of them in Texas, and any new one coming in has to be inspected. And then any new service coming in, we inspect the whole operations. And then we have the option to inspect at any time and do what you all may know as surprise inspections, those kind of things. We also do inspections of first responder units. You know, as I said before, it's mostly fire trucks, but it could be specialized vehicles, air ambulances, I think I've already said. And then we also do inspections of EMS education programs, as well CE, as well as full basic and advanced programs. And then we do investigations. And we have a group of about 40 staff that are truly dedicated EMS providers. All of us have some kind of background in EMS and a lot of history in EMS. And when we do investigations, most of you or a lot of you probably know Brett Hart, who's been in Texas forever. It's so interesting when we meet with people in investigations, we say to them, you know, try not to give us mistruth or lie to us or bad information, because we have a lot of experiences in the back of the truck. I started in '74. Brett started in the '80s, and what I would say to people, we've kind of got away with it, but you're now sitting in front of the state office. So, you know, we understand the ins and outs of the truck, and our mission is to be customer friendly, and we support our stakeholders, but we will also take discipline action if we need to clean up the process, but we're always respectful at it. You may move to the next slide, Kat. So what is our process for an application? So an application comes in, and let me just talk about the initial. So the initial application, it's a whole packet, it's all online. They go in, they fill it out. We get the copy of their protocols, understanding that Texas is a delegated practice state. So what does that mean? So when I was in Pennsylvania, everyone in EMS operated under the statewide protocols. In Texas, each of the organization has their own protocols and their own medical director. I know in Pennsylvania, we had a medical director, but they were just evaluating our skills and accrediting us, credentialing us, I should say. But in Texas, the medical director does all of that here. So each organization has their own protocols, and we get a copy of them. So we get the application, we get a copy of their protocols, their QA plan, their equipment list, and all of that comes in. And it comes into our licensure office, which is a little bit different than other states. In Pennsylvania, licensing came under the EMS office. In Texas, licensing is under the license division. And then once they do and check the boxes to make sure the application is complete, they don't review it for content, they just review to make sure the documents are there. Then it goes out to our regional office. And those staff, which are all experienced EMS personnel at one time or another, they review it for completeness. They look at the protocols. Does the protocols match up with the equipment list? Does the equipment list and medication match up with the protocol? If they say they're going to carry in the protocols that you're going to have Valium on board, then equipment list should say that there are Valium on board and how many there would be and stuff like that. So we look at that. And then we communicate with the person, the provider or the education program, because we deal with both. And we talk about their equipment list, what they're trying to do, and then we set up a time to do a virtual inspection. In the past, we would go out and do that inspection. Now it's all virtual. You may go to the next slide, Kathy. So when we set that up, there are obviously some pros and cons to it. It's a fast turnaround. You could call us today and we can go out and do a virtual inspection this afternoon. It saves a lot of time and money. I think I have a slide later on that'll talk about some of the savings, but from a state standpoint, if anyone's been on a call with Joe Schmieder, you've heard me say, I think our next disaster is going to be the financial impact of this coronavirus on all aspects. We're looking at patient care records in Texas, and we're probably about 17% down where we were this time last year on call volume. So that's going to be a challenge because we all operate on making calls. But this virtual process that we put in place and coordinating, we use FaceTime, we can use Teams, we can record it, we can use Zoom. We have a phone call the day before, we coordinate all that and make sure it all works. And then I'll talk a little bit more about that, I think, in another slide here. But it gives a lot of flexibility to the staff and in the EMS organizations and to our own staff here. And we, as I said before, we can turn it around pretty quickly. And it also protects our team, our workforce, not going out. If we can still go out and do inspections, and we have, but if we're going to go out and do an inspection, the first thing we do is to verify the last time the truck was deconned, when was the last time it transported it, when was the last time it was cleaned after a patient. Because the one thing I don't want is any of our workforce, and two parts of that workforce, the team that works for the state and our stakeholders' workforce, to have an adverse effect because of coming in contact with the virus. So we want to always keep that, and that is on the front page of our minds, on the front of our minds, and is always built into everything we do. Is it safe? Because we want to make sure that, as on the fire side, everybody goes home safe at the end of the day. The con to this is I am really concerned about the lack of building those rapport. You know, sometimes it's a whole lot easier to have a conversation with somebody on a face-to-face conversation and than it is through a webinar or Zoom. And I am probably like a lot of you here, when I'm on a webinar, I gotta really focus on what's being said, and I shouldn't be on my phone, I shouldn't be looking at emails. I don't wanna lose that part of the relationships that we build over the years by going out. And one of the hardest things for me is that I am just been raised, like most of us, that when I meet somebody, I greet them and I shake their hand, and my natural instinct is to push my hand forward, and we know we can't do that. We all struggle with that. So we gotta be conscious of our relationships. It's hard when we're doing these virtuals to realize what's going on around us. You know, when you go to a building and do an inspection, you know, one of the things that's always set my radar off when I've done inspections is that the building's really dirty and sloppy, man. I just know the inspection's not going to be a good inspection, and you lose all that. You just see what's on that screen. And we have never given up the right to go out and do an inspection, but that ability to see what else is going on, you do lose that. There's no doubt about it. But we'll get back there someday. But in the meantime, we don't want to hinder the system from moving forward and being able to get these vehicles in service as we need them. You can do the next slide, Kat. So here's some of the summaries from March of 2020. We've done 153 inspections of vehicles and EMS education programs. We estimate that we saved $30,580 in travel costs and about 750 staff hours by not traveling. And that's a big deal. And in some states, you may not have that kind of savings because the distances are smaller, but that's a big deal for us here. And even if you just figure, you know, $30 an hour for the staff person to go out, or $25 or 20 hours, just start doing the math. And in this crazy COVID world and the budget challenges we're going to have going forward, any savings is a savings. There is no doubt about it. And when one of the things that we do when we go out and do these, as I said earlier, we communicate the day before. We make sure we all are in agreement on the technology that we're going to use to do this. If it's an ALS vehicle and they're carrying drugs, we ask them to lay the drugs out first so that that they can show it. They can pick up the vial. You can see what the drug is. You can see the expiration date, and then it follows their equipment list. If you just follow that list, and you can just walk right through it, and they can do it, and it works really well. If someone emails me, I can send you some, and I'll show you my email address in a second here. I can send you some videos that we have done with services so that that you can see what's going on. And by using Teams, which is the platform we would prefer, we can record that if need be. Understanding we'll get their permission to record it and then to share it. Next slide, please, Kath. So what have we learned? So, you know, the video works. It keeps us operational. We started this very quickly back in March because we knew we needed to move equipment around and we wanted to make sure we weren't shut down. It allows us, even at the air ambulance level, I mean, we can do it all, and we can turn it around in a time that works. It does benefit the process if one person, it's a 3-person operation. It's us, you know, sitting at a desk or whatever. It's very beneficial if someone at the EMS provider end of it is carrying they're like the camera person, and then a person getting the equipment and showing us the equipment. That works the best. And then laying everything out ahead of time so you're not jumping all over the place. You need to really figure all that out. And in the video, you know, you will see staff walking up. They're holding a camera, walking up, and they say, okay, let's see the VIN number on the vehicle. Let's see the license number. Let's see the inspection sticker. Turn on the siren, turn on the lights. You can do all of that. And it really, it's a little bit longer, but it really does work, and it does keep your system operational and keeps you moving forward in meeting the requirements of your job. And the last and final slide is my contact information. Oh, maybe is it after that? Is there one more slide after that? No, that's it. Kathy, would you go all the way back to slide number 2, please? So here is my contact information. Please don't hesitate to call me or email me, and I will share everything and anything I have. We have put together a document, a little handbook on how to do these, the pros and cons. So don't hesitate to ask, and we'll share it with you. So there's no sense in everyone creating their own documents. So with that, Kathy, I'll stop, and I don't know if we're doing questions now or doing all at the end or whatever. Is there anything, Kathy, you think I need to repeat or emphasize?
Joe, that was very informational. We really appreciate your effort. I think we can take a few questions right now.
And I can't see the chat box, so if there's anything in the chat, if you can just read it for me and I'll answer it, or we can do it verbally, whatever.
Okay.
Or I guess I could look in the chat box. No, that's Windows.
We're looking on our end to see somebody raised their hand. I'm not seeing it right at the moment. I'm going to unmute the microphone. So we'll see if we can catch it that way.
And I'm going to stay on. I'm not going anyplace. So we get to the end, we can do it then too.
Okay, great. Well, we do have some questions just in the question chat box that I can go ahead and read, Joe, if you want to answer them. Does that work?
Sure, please.
Great. So this is from Sam Vance, who says that you mentioned that you have still done some in-person inspections, and he just was wondering, in what situations are you doing those?
Well, first of all, if Sam Vance is asking that question, are you kidding me? No. Good morning, Sam. Yeah, we do that for two reasons. If we did a virtual inspection and it really did not go well, then we'll go out and do an in-person inspection. But I don't think Texas is any different than any other state. There are just some services that you just need to go out and look for whatever reason. They may have a history. So they would be the two scenarios. They had a really bad virtual inspection, or B, they're already on our radar for one reason or another.
Great, thank you. And then our next question is from Sabrina Kerr, who said, what do you do for very rural agencies that do not have video capabilities?
We have not found that yet. We have done as simple as FaceTime using somebody's phone. So we have not had anyone who could not set it up. That's why I strongly suggest that you do it ahead of time and figure all that out. And if we did come across where we just couldn't, make the connection, we will go out and do a real inspection, in-person inspection. We still have that option, but this just makes it easier, and we have not had any place where we couldn't do it.
Great, thanks. And then another question kind of along with that was just asking if there are any challenges in managing the method with rural communities, but was there anything, in addition to the video capabilities that you guys have faced?
Yeah, we've had a couple communities where we lost and we had to redial and stuff like that. But I think the most important message of this whole presentation is try it out the day before when you're not under the gun and try to get it done. Just work it and make sure that the connections work. And sometimes more complex makes it harder. FaceTime may be the best method you can use.
Is that the only technology or platform you guys are using? Is FaceTime, or is there a specific one you guys are using every time?
We use FaceTime, Zoom, and Teams. Whichever works at both sides have the same connection.
Great. And then pivoting a little, do you have to see emergency rules to allow you to schedule inspections versus unannounced or surprise inspections?
We already have our rules that we can do it at any time. We can just do it.
Great. Do you apply a permit to vehicles? And if yes, do you mail the permit to the agency to have them apply it?
Yeah, so they have a license. We will, once we complete the inspection, if we do give them it's like a permit, a document they put in their vehicle, but we can approve them to start running immediately while the mail system catches up and gets it to them, because we're going to know that they're licensed and that vehicle is authorized by us. So we don't use the paperwork as a process to delay somebody from using a vehicle. We want to get these vehicles in service as quick as possible.
Great. And then you have a lot of you're very popular. We have a lot of questions still coming in, but do you have a written policy or procedure around the process? And are you open to sharing that if people just reach out to you via email?
Yep, we have a manual that we put together that talks about the process. It's really detailed. It's all of about 15 pages, but I will share that with anyone. That's public information. So drop me an email me, or Kathy, I don't know if I send it to you. Can you just send it to everybody on this call? What's easiest for y'all.
Yeah, Joe, I did put your contact information in the chat box. So okay. Hopefully people are able to snag that there.
Okay, and then I know later this week we're going to post it, but I'll send it out today to anybody who emails me.
Perfect. Thanks. We appreciate that. With your inspection results, does your team use any electronic systems to document it?
Yeah, we have a tablet that we use. It's everything we do. We've kind of moved away from paper as much as possible. So they're working off of a tablet, and I know I should know what the initials are, and I don't. I'm sorry, but it walks them through, and they're checking the box, and they can put notes and stuff like that, and it generates a report when you're done.
Great. Do you guys ever look at patient records, and then how are you working to ensure privacy and confidentiality with the video platform? Is that something you review separately?
So if we're looking, so for initials, they're not going to. We need to see that they have a QA plan on initial certifications. For renewal, the only time we would look at that if we had some issues that we're aware of. We will be looking more at that in the future, but right now that has not been a hang up. And in that case, what we probably would not look to do something virtual with that because of the HIPAA requirements. We would probably go out and look if there was some concerns about that. We would physically go out.
Okay, and then I think kind of looks like maybe our last question for this morning is, how have your stakeholders supported and embraced the method? Are you hearing any concerns from them about the methods you're using?
No, I have only seen positives. They were thrilled to death that we're able to turn around as quick as possible because in most cases, it was really around the education, around the EMS vehicles. They needed that vehicle, so this way we could turn it around pretty quick and meet all the requirements of our rules. From the education programs, there has not been a complaint. People have embraced this, understanding that this is the new world we all live in, and have welcomed these opportunities to make sure we weren't holding them up from meeting their mission on providing EMS or providing education.
Hey, Joe, this is a great presentation. I know lots of folks are trying to deal with that issue, so we appreciate you putting that information together and taking your time today to explain it. We have shared your contact information in the chat box, and obviously if people are having a hard time finding that where there is on their screen, they can email me at robinson@nasemso.org, and we'll make sure to connect with you. Thanks, pal. That is just really greatly appreciated.
It truly is my pleasure, and thank you for asking me, and I'll hang on here, and I'm interested to see how everybody else is doing it. Thank you.
Well, I'm sure that the upcoming speakers will have received some value from the questions that our folks have asked, and you know, we'll manage to continue the discussion. All right, let me. I'm going to. And if you can help me get to be the presenter, I'm going to pull this next slide presentation on my screen.
Yes, absolutely. One sec.
And while she's doing that, I'm very pleased to introduce Carol Mays. She's from the Maryland Institute for Emergency Medical Services Systems, the Director of Trauma and Injury Specialty Care Program. Carol has actually served as chairperson of the Trauma Managers Committee. We've certainly gained a lot of knowledge and guidance from her. So Carol, thank you very much to you for joining us today and talking about your current experiences with regards to trauma center designation. So without further ado, I'm going to go ahead and turn it over to you. I think you should see your slides on the screen now. We'll operate them from this end.
I do. Thank you very much. Good morning and good afternoon, everyone. I thank you for letting me tell you a little bit about the MIMS virtual survey story. Next slide, please. Next slide. Thank you. So once upon a time, coronavirus came into our lives, and it kind of disrupted what we do with our normal survey for verification, inspection, or follow-up that we do with our hospitals and our agencies. So we're banned for any out-of-state travel. The Maryland state non-essential employees began teleworking from on March 13th. There was a closing of hospitals to any visitors and surveyors. We had upcoming re-verification surveys coming up and follow-ups for provisional in June, July, August, October, December, and February. So again, I'll talk to a little bit about that in a minute. Our out-of-state surveyors were unable to travel out of their state for any surveys. So that was also an issue that we had. Next slide, please. Thank you. So these are all the surveys or inspections that we do within hospital programs. The base stations are done by our regional programs. Commercial ambulance inspections are done by the State Office of Commercial Ambulance Licensing and Regulations, which is SOCLAR, and that's under Lisa Shervon, and actually it's done similarly to the way Joe and Texas do theirs. We have perinatal surveys, cardiac interventional surveys, stroke surveys, trauma, adult and peds, eye trauma, hand and upper extremity, neurotrauma, and burn for adult and peds, and we do those with the ABA. So, thank you. That's okay. Our surveys are done every 5 years, so it was important to us to kind of stay on track. And so what we decided was to do our surveys for all of the programs, if possible, similarly. So what we found is within our COMAR, which is the Code of Maryland Regulations, we have on-site survey throughout all our regulations. So it's the telehealth definition here is from the Maryland Board of Physicians, and it's going through the state documents right now. So we wanted to make sure that that was identified. So next slide, please. So our aim was to stay as similar as possible to the regular surveys that are known, especially I'm going to just talk about trauma right now, but we send out a notification letter about a year before the survey. We contract with out-of-state surveyors, so all of trauma is with out-of-state surveyors. We agree for the survey date, and this is done about a year ahead. Our applications are sent. So some of the applications were already out prior to our March 13th telework. So what we decided was to send the trauma center a letter just to say that this on-site survey will be changed to a virtual survey and we need your agreement to proceed. So we had to change the on-site survey agenda to a virtual survey agenda, but they look very similar. It's just the timeframes are collapsed some, and we had to make sure that the trauma center, the hospital, could do their part of the Zoom or Google Meet or GoToMeeting in order to have the on-site the virtual surveyors and of course the MIN staff to go ahead and be able to see what they're doing in their facility. So preparation is as it always was. You know, we again make sure that the surveyors have a copy of the application. You can next slide, please. Oops, okay. This is just a copy of the notification letter and the agreement on part of the hospital that they'll accept a virtual survey. You can go to the next slide, which is a re-verification survey for virtual. So it's basically what we've always done, except that we've collapsed things. I have a survey next Tuesday, and we went over this yesterday with the site. And there's some things that we said, well, we can collapse that a little bit more, or we might need more time for additional questions. They have set up all their Zoom meetings, and I have set up my virtual meeting at 2 o'clock so that the surveyors and myself can talk about the medical record review, the performance improvement, what they've seen in the application, etc. And then we have a brief exit meeting, which generally takes less than a half hour. However, we made it a half hour in case there are additional questions. Next slide, please. So our medical record review, we've always done it at the hospital. Each of the surveyors get 10 charts to review, and I actually pick those charts out of the audit filters for that particular trauma center. I've done medical records in two different ways. One, I did a review in June, and I worked with one of the trauma centers with their registrar, and I did my medical record reviews using that registrar's Epic, and we went through the whole chart. I went through 20 charts by Zoom, actually. And by the time we got through about 2 of the charts, she knew exactly where to go, where I was heading. I wanted, EMS, the arrival, ED, all the progress notes, OR notes, discharge notes, etc. That was a little painful, and it took a lot of time. So we decided to ask the trauma center to encrypt either flash drives or CDs. For the survey I'm having next week, I haven't heard a peep out of the surveyors. They must be doing their medical record review and not having issues with it. However, I wanted to let you know that if they do have questions, we asked the hospital to be sure that there was somebody that they can share screens with the day of the survey, virtual survey. Usually the night before, the survey team would meet, and we would review the application and formulate questions that we wanted to ask of the trauma center. What we have done because of the virtual survey is we've met, I'm going to say probably 3 times, with one more coming tomorrow for the survey team next week. First, it's so that the survey team can meet each other, because some of them haven't worked with each other before. And our team is trauma surgeon, emergency medicine physician, and a trauma program manager director. Let's see. So again, we are going to meet again tomorrow, for instance, just to go over the things that we want to make sure that we speak to or ask them for the day of the survey. Next slide, please. So I do send a letter out prior just to say thanks for the application. Here's the date of your survey. Here's the virtual agenda. Here's how we're going to do medical record review. These are the names of your trauma survey team. And at that point, I do send them their CVs. And any direct costs, which are actually going to be less for the hospital at this point, because there's no travel costs. And again, we talk about what we'll do at the exit meeting, and that we have 45 business days to provide them a re-verification survey letter and report. Next slide, please. So again, we're trying to keep to the on-site survey process. We modified it for virtual. We have a checklist that we use to verify that the regulations are being accommodated. So we do that both with the on-site and the virtual. Again, we set up online meetings with the survey team. For the virtual tour, it's we've always done a tour through the emergency department, ICU, OR, PACU, and some of the key areas. This time, the hospital will be using not the workstation on wheels, but they're going to be using their iPad, and the nurse manager will be taking us through those particular areas and talking about the trauma resus room and other parts of their department. Our PI reviews are being sent with the CD and encrypted CD or flash drives. And if there are additional areas of the PI review that they would like to see that they didn't see, or they have questions about the day of the survey, we've asked that they have their PI person available and to be able to share that with us. We do ask with the virtual survey to have the hospital IT staff help out if there are issues with the Zoom, the GoToMeeting, or the Google Meet. Next slide, please. And I basically told you about the medical record and case review. Again, we do 30 records. We're doing 30 records with virtual as well. We do have a medical record review form that's used, and a standard form that's used for both on-site and virtual. And I told you about the 2 different ways that I've done the medical record review so far. So next slide, please. And again, at the end of the survey, within 45 business days, we look at the compliance to regulation. We look at the trauma center's strengths, opportunities for improvement, and that goes into a letter and is sent out to the president of the hospital. Next slide, please. Okay, so I wanted to say, when we talked about this at the trauma program manager or trauma manager council, I wanted to let you know there are some other states that are doing virtual surveys. And Chris Ballard at Minnesota shared this with me, that they are doing on-site surveys, that they have guidelines for the reviewers and the hospitals that WebEx is used, and that they don't really see the existence of required equipment, but they do have an attestation regarding the presence of the equipment. And they do have a sample agenda also. Next slide, please. Liana Lejean in New Mexico said that they do level 4 trauma centers only, and that it's basically the same process that they've had. This facility does send the 10 charts that are pulled from the trauma registry as well. And if they have questions, they're ready for a video call. A callback is done in the afternoon with the findings, and they're not planning to do level 3s virtually. Those surveys require a surgeon and often have a surgeon-to-surgeon discussion. And the level 3s have been given a 1-year extension. Next slide, please. Then we have South Dakota, and they treat the virtual surveys as on-site survey. I think, as I remember, Rebecca said last week that she was back doing an on-site survey recently. They use the same agenda for rural trauma centers. The biggest obstacle is the case review, and they use a shared folder for the nurse reviewer to review cases prior to the survey. Cam said that in Virginia, there was a recent virtual survey as well. There are probably other states that are surveying virtually, but I did want to say that Maryland's not the only state doing this, and I wanted to just give a shout out to those folks that are doing this. Next slide, please. So our future verification survey thoughts. We feel like the first verifications, if in future this is the way we go, the first verification for designation should be a full on-site review. In some cases, we could have hybrid surveys where part is in person and part could be virtual. And we also thought that the mature centers may require less repetitiveness with in their application, within what they're sharing with us at their surveys, because we've been there many times. So next slide, please. So this is the end of my conversation, but I'm not so sure this is the end of our virtual surveying, and wondering if this is our new normal. Thank you. Questions?
Carol, yeah, that was a great presentation. We actually do have a question in the queue. Are your hospitals requiring you to sign business associate HIPAA agreements prior to giving you their medical records?
No. No.
Well, that was an easy one.
Yeah, remember our surveyors, they sign a confidentiality, and yeah, confidentiality within the contract.
I'm not seeing any more questions coming up in the question box, but there was one that I think came in just as we were transitioning, and I suspect Joe's still there. Do both of you expect that this is going to be the way of the future, or do you think that once there aren't concerns about coronavirus that you'll go back to the way that you were doing things?
I think it could be the way of the future, or maybe a hybrid of some sort. I can put my webcam on so you can see me.
Oh, now we're getting more questions. Go ahead, Joe.
I would agree also. This is, if anyone thinks it's not going to continue on like this, I think you're going to be wrong. I think this is the future, and we need to embrace it and just make it better.
Carol, did you have your contact information on one of your slides?
I do not, but I can put it in the chat box.
That would be great.
All right.
Some requests for that, so folks can reach out to you directly, and we can make sure to share too. So does your team use any electronic system to manage the hospital application and the survey result?
Oh, we've tried to use, in the past, we were trying to use electronic, like sort of a cloud within NIMS. But it was hard when some of the surveyors didn't have the technology at their homes that others might have at the hospital that they work in, perhaps. So we're paper right now. I have offered to do the medical record review to the surveyors, to do it on the computer, and they like doing it on paper. I take all the paper copies and I scan them in and throw them on a CD. Did that answer your question?
I think that it did. I'm getting a lot of messages in the in our messaging platform there from your trauma manager colleagues, thanking you for a wonderful presentation. So I did want to sort of pass that along.
They're wonderful.
They are a wonderful group indeed. Okay, I think that I've reached to the end of the trauma questions, and I think it's time for us to move along to. We'll make sure that we get you Carol's contact information. We'll move on to introduce our next speaker, Evelyn Lyons, a great friend in the NASEMSOs again, and a great friend to EMSC, someone that we've all looked up to for a number of years and looking for pediatric guidance. It's had some experience with the evaluation of pediatric emergency department, and we're just very happy for Evelyn to welcome you and for you to share your wisdom and experiences today. All right, well, I think we might have you on mute, but we'll try to fix that. Evelyn, are you there?
I'm here. Can you hear me?
Yep, we can now. We're
Oh,
good for you
great.
to go. Thank you again.
Okay, thanks so much, Kathy, and hello, everyone. This presentation, as Kathy mentioned, will review the virtual survey process that we developed through our EMS for Children Pediatric Facility Recognition Program in Illinois. Next slide. To begin with some demographics, this is an overview of our state. Illinois has a fairly large population of 12.7 million with a correspondingly large pediatric population. And the graphic on the right side of the slide is our state divided into 11 colorized regions. And this regional structure is how oversight to EMS and trauma services is provided. Our EMSC program adopted this same structure with our facility recognition program as well. And to provide some geographic perspective, the upper right sector of that map is a more urban, suburban area within our state. And Region 11 actually is the city of Chicago. It's its own region. And then the rest, fanning out from there, the rest of the larger size regions are primarily rural with some urban pockets. With respect to hospital infrastructure, our state has over 200 hospitals. Some are specialty hospitals, such as psychiatric, long-term care, or ventilator hospitals. And you can see that 185 hospitals have emergency departments, and then 111 of those, or about 60%, participate in our pediatric facility recognition program, which helps to assure that we meet one of the federal EMSC performance measures related to emergency department pediatric readiness. Next slide. So this hospital designation process helps us to identify those hospitals who've taken the steps to assure their readiness and capabilities to provide optimal pediatric emergency and critical care. And it's a three-tiered process with the first two levels focused on requirements related to the emergency department. Those are the EDAP and SEDP levels, and the number of hospitals in our state participating in those levels are listed there. And then the top level in the tier is the Pediatric Critical Care Center. And this level goes beyond the doors of the emergency department and identifies those hospitals that have pediatric intensive care units and specialty inpatient services. This is where the more critically ill or injured child needing more definitive care would be transported to. Now, we began this whole process in 1998, and each year we conduct in-person site visits to assure ongoing compliance with the requirements. But it takes a 4-year cycle before we get back to each region. So we typically conduct surveys twice a year in the spring and late fall, and we conduct surveys each year in 2 to 3 regions. We anticipated surveying the hospitals in our southernmost regions, which are regions 4 and 5, you can see there. We had planned to do those this spring. However, obviously with COVID, those needed to be postponed. And then as we move further along, we decided we were going to have to look at conducting virtual visits if we wanted to stay on track with our schedule. Now, what's a little unique with regions 4 and 5 is that they're very rural, and so we weren't really sure if there might be some IT issues or other issues as we moved along with it. But overall, we were really nicely pleased with how things turned out. Next slide. Now, the requirements for each level cover the bulleted areas noted on this slide. So there's facility requirements that need to be in place. In addition, there's people requirements. So physicians, advanced practitioners, and nurses need to meet specific qualifications, credentialing, ongoing pediatric continuing education, as well as there's specific coverage and backup availability. And then there's pediatric policies, treatment guidelines that are required, as well as interfacility transfer guidelines and transfer agreements with tertiary care centers where they transfer children that need that level of care. And the transfer piece also helps us meet 2 more federal EMSC performance measures. Quality improvement is a key component of our program, so hospitals need to have a committee in place, as well as a physician and nurse who serve as the primary advocates and coordinators for pediatric care in the ED. And then there's checklists that we have outlining equipment, supplies, and medications that need to be available. And during our in-person visits, we typically go around and actually visualize all of the items and check them off after confirming their presence. In addition, pediatric disaster preparedness also has a checklist, and it's a key component that we look at specific criteria to make sure that they're as prepared as possible to address children's needs during a disaster. So you can see there's a large volume of documents that would be associated with each of these aspects of the review, which isn't an issue when we're on site at the hospital, but we needed to brainstorm as to how best to approach this from a virtual perspective. Next slide. We began planning the process a few months out from the surveys, and the plan was to try to address all of the same areas and try to use the same similar format as we do with the in-person, but just look at how we could translate it to a virtual process. So we had 22 surveys that we were planning for August and September. And we went ahead and scheduled those based on surveyor availability. And hospitals were notified of their survey date and time, and we let them know that as we continue to move forward with the process that we'd be providing them with further information. Now, each survey team is comprised of a physician and a nurse surveyor, as well as a surveyor with pediatric disaster preparedness experience. And then in addition, we had 2 state Department of Public Health representatives, myself and our EMSC coordinator. And one of us alternated as the survey facilitator. And we realized that this really turned out to be very helpful, because it was really, we found it beneficial to have one person who was just dedicated to fielding any questions, troubleshooting any issues, and providing technical assistance that might be needed during the survey by the survey team members. Another piece that we needed to identify was the webinar platform to use, and we actually ended up using 2 for every survey just to have a safety net in case that there were any issues. And so those were WebEx, which our state health department has a WebEx license. And then we also have a grant partnership program with Lurie Children's Hospital, and we were able to access their Zoom capabilities. And this is an academic Zoom license, so we felt confident that it would ensure security of documentation and ensure that confidentiality that's needed based on the documents that we reviewed. And then we also developed a guidance document for both the hospitals and the surveyors, as well as a training presentation to walk all of them through the process and outline expectations. Next slide. Using the materials that were developed, we conducted online educational sessions for the hospitals and the surveyors. Hospitals did identify that they were using more remote methods for communicating and for meetings. However, some of them weren't using WebEx or Zoom, and some were doing it to varied degrees. So we wanted to be sure that there wouldn't be any platform or connection issues, and kind of followed the approach as has been previously mentioned about doing a test with the hospitals. And so this was really key, that test piece. So we requested that the key personnel who would be involved in the survey participate in a test. And so we scheduled those. We also asked that their hospital IT participate as well. We asked them to test each computer or laptop that they'd be using during the survey. And again, this was important because we'd have hospital personnel test a computer and it worked well, but then during the survey, they were using a different laptop that hadn't been tested. And then we found that they were having problems that it could have been prevented if we had just tested the computers that were actually being used. And since there were specific documents that needed to undergo review, we needed to confirm that they could access whatever server or folder or drive was needed, that those computers would have access to those materials. And we found that that was particularly an issue that we encountered at several hospitals regarding access to their electronic medical record. So they never sent us the electronic medical record. That was something that was reviewed at the time of the survey. So if the EMR review was going to take place in a boardroom or a conference room, or sometimes wherever they were planning to situate the physician surveyor for that part of the review, sometimes the computers in those rooms didn't provide access to the EMR. So by making sure we talked about that ahead of time, then IT could make sure they configured and set those computers up so that there was access to their Epic or Cerner or whatever their electronic medical system was. And so this just became a standard question that we not only asked, but as part of the test, we actually had them go through the process of sharing their screen so they could familiarize themselves with the webinar platform. And then we had them actually open up a few documents and access their EMR so that we could be sure that they'd be able to connect to those components during the survey. We really wanted to ensure that those who would need to share documents with us would be comfortable with the process, or if not, then we asked to ensure that a support person would be present to provide that assistance. And then we also asked that hospitals have their hospital IT accessible during the survey, and that worked out well as well. Next slide. This is a slide from the hospital training in which we emphasized the need for 4 electronic devices, since you'll see in a minute that we had 4 breakout sessions during the survey. We also mentioned that having camera capabilities would be helpful as well. Next slide. We also requested documents to be submitted prior to the survey. So they do submit a renewal application. And we've only done this now with renewal, hospitals going through renewal. We have not done it with any hospitals newly requesting recognition. But in addition to that application, there's additional documents that are reviewed at the time of the survey. So some of them we felt we would just do during the survey itself, but we identified that there were some that could be submitted prior to the survey to assist the survey team with the document review process. And this is just an excerpt from the guidance document that we developed that outlines some of the documentation that needed to be submitted by the hospitals at least 10 days prior to their survey. Next slide. We didn't request any documentation that would contain patient identifiers or patient information, but we still needed to ensure confidentiality in the transmission. So there were 2 mechanisms in which they could submit these documents. And understand that some of the documentation that we requested were photos or videos of various items or rooms at the hospital. So due to size constraints, it would have been sometimes difficult for them to send that via email. So as seen on this slide, which we shared during the hospital training, they could submit the documents via a secured file transfer process that our state has in place, or they could email them to both myself and Kelly, who's our EMSC coordinator. Next slide. Here's some examples of photos that were sent, just to give you an idea of what we requested and received. And obviously, it's not the same as actually touring the units, but it did help to provide us with a sense of what they have in place. They were to send us a checklist of everything, or a content list of everything that's in their Pyxis and their medication dispensing system and their supplies. But in addition, there were a number of supplies and equipment that we actually wanted to see photographs of. So we asked about infant resuscitation equipment and warming devices, and you can see on this slide that one hospital provided us with a photo of their overhead warmer. The middle photo is a Braslo cart, and although we don't specifically require Braslo carts, the hospitals do need to have a pediatric resuscitation cart, and they also need to provide us with a content list by drawer so we can kind of get a sense of the inventory and how that's set up. The last photo is of a triage room, and you can see in the back left side of the room is an infant scale, and a national patient safety measure is ensuring that all weights are obtained in kilograms because medications are based on weight in children. So during site visits, we'll actually go up to the scales and we'll test them to make sure that the scales are locked out to weigh only in kilograms. And so we wanted to ensure that this was also in place. And so we had them submit a video, and you can actually click if you move your cursor down to the bottom and play that. Maybe it's not working.
Going to hit the unit button. It shows me that it is locked.
Okay, so that one even had some audio to it, but really we wanted to confirm and that the scales lock out to kilograms only. And this is needed not only on the infant scales, but also the standing scales and the bed scales as well. Next slide. A few other key supplies that we asked about to confirm by photo were airway supplies, various size blood pressure cuffs, and intraosseous access, which you can see on this slide. Next slide. And then from a disaster perspective, we always want to ensure that photos can be taken of unaccompanied children during a disaster to assist with reunification. So the hospitals need to have a camera, which is pictured here. Also, kids are at higher risk for hypothermia during decontamination. So we ask what's their process for measuring the water temperature, both before and during the decon process with children. And so there's two mechanisms just shown here. One is a handheld device, and the other is a temperature gauge attached to the water line. And so in addition to having the equipment or the capabilities, they also need to have temperature monitoring of the water incorporated into their decon policy and plan as well. Next slide. So you can kind of see where the photos helped us. Some key points, the survey consisted of an opening session, 4 document review sessions that were conducted simultaneously, and then a closing session. And all of this was conducted over a 4-hour time frame. An agenda was developed for each hospital that contained the webinar links for each session, and the survey facilitator and designated surveyors would then activate the webinars. Everyone was asked to log into the sessions at least 10 to 15 minutes prior to the scheduled start time. And we tracked to some degree the record of attendance during the webinar platform. However, since some of the hospital personnel weren't actually present at the hospital and they logged in remotely from home or office, we did ask the hospital to send us their sign-in sheet or roster to confirm who actually participated. Next slide. Because of the confidential nature of some of the documents undergoing review, the document review sessions were locked while in session, and I think we might be off by a slide. Let me see here. We should be on slide 15. I think we might. Let me just see here. Yeah, there you go. So because of the confidential nature of some of the documents undergoing review, the document review sessions were locked while in progress, so we could then ensure that no one else was accessing the information or discussion. And this would be particularly important for the electronic medical record or certain kinds of QI information that was being shared. And then we did record the closing session, which we typically do during the in-person sessions as well. It just helps us better capture information conveyed by the survey team, and that assists us with the post-survey report letter. And everyone was made aware that the closing would be recorded, and we announced that we considered their participation as consent to being recorded. We also made the recording available to the hospitals as requested. And I've mentioned that we had one person act as a survey facilitator, and this person's cell phone number was shared with the team so they could text or call each other if they encountered an issue or had questions. And then the facilitator would also join in different document review sessions to just monitor to make sure everything was moving along, and also to let the surveyors know. They provide them with a time check at 15 minutes prior to the end of the session as a reminder. And we just wanted to provide some additional support to the survey team members because this was the first time they were doing this as well. Next slide. Here's a sample agenda that was shared with the hospital, and it's minus any webinar links or names of the survey team. But the opening session is noted here, and we allotted 45 minutes for that session. And just be aware that prior to that opening session of every survey, we actually had the survey team meet by phone via a conference call number. And it was just a short little call, but it allowed us as a team to touch base, review any key points, answer any last minute questions, or clarify any issues that someone might have. And then once we were clear that everyone was on the same page, there weren't any outstanding questions, then we were able to move to the opening session. Next slide. The opening session began with introductions, and although this might seem like a minor point, because it was being done virtually, there is the potential for people stepping over each other as they're trying to do introductions. So we came up with a standard format of doing introductions to try to avoid that. So the survey facilitator would start out with the survey team introductions, and she would call out each survey team member to introduce themselves. And as each one individually introduced themselves, then once the survey team was all introduced, then the facilitator turned it over to the point person at the hospital, and then they led their introductions on their end. So it really just tended to move along very smoothly with that setup. And then the physician surveyor provided a brief overview of EMSC, facility recognition, and the purpose of the survey. And then it was basically turned over to the hospital for their presentation. We always have the hospitals begin by doing a SWOT analysis. And with that, they review their strengths, weaknesses, opportunities, and threats in regards to their pediatric readiness. So it provides a nice overview of their status. And then that's followed by their demographics, their patient volume, their patient breakdown, transfers, QI, and disaster processes. And then time was allocated for Q&A as well. Next slide. Next was the document review session, which was allocated 75 minutes. And be aware that there was a lot of documentation that had been provided ahead of time for review. So that helped as well. And then we also built in 15 minutes between the sessions to allow the hospital personnel and the survey team to transition to the next webinar platform, and also to just have a little bit of a brief break. So for the document review sessions, the physician, nurse, IDPH representative, and disaster coordinator each took the lead for each of their individual sessions. And then just the hospital personnel who needed to participate in each of those sessions was in attendance. They could have as many people as they wanted to participate on their end, but we just reminded them that each of the sessions would be locked out after they confirmed that they had all of their folks present and accounted for. Next slide. This is an excerpt from the survey guideline document that outlined what needed to be available for the physician surveyor to review related to the physician component. And each of the other three components also had one similar that was provided to the hospital. So for the physicians, in addition to all of the other documentation that they previously reviewed, they needed to share their physician staff meeting minutes, their continuing education files. And then prior to the survey, the hospitals, we gave them a time frame. And within that time frame, we gave them certain kinds of patient conditions, such as fever under the age of age 2, head trauma, seizures. And so they had to pull together a list of ED visits, no identifiers, just a list of ED visits that occurred for pediatric patients during that time period. And then we reviewed the list, and that list was connected on their end with a medical record. And we just let them know a number of records to pull and to have available for review at the time of the visit. So that was another component that the physician was involved in doing, was those medical record reviews. And then if the surveyors had additional questions or needed clarification regarding any of the documentation that was reviewed prior to the survey, that could also be discussed during this breakout session. Next slide. So after the conclusion of the document review session, the hospital personnel could then take a break, and the survey team conducted a huddle. It was for 30 minutes, and it was using the designated conference call line that just the survey team had access to. And this allowed our survey team to kind of brief each other on our perspectives and what happened in each of our huddles. Because during the in-person, we're right there with each other. We can talk among ourselves, and we do a separate huddle at those visits as well. But this allowed us a little bit of time to talk to each other, get a little bit of a briefing from each team member, and prepare our remarks for the closing session. Next slide. And then the closing session was the culmination of the survey. And during this component of the survey, each survey team member conveyed positive aspects of the survey, and then any gaps or opportunities for improvement. The session was open to questions from the hospital personnel. And even though we do take handwritten notes, this session was the session that I mentioned is recorded so that we just can have that information easily accessible to help us with the post-survey report that's sent out to the hospitals. Next slide. So all in all, we thought the virtual survey process went well. We definitely learned much, and it allowed us to stay on track with our renewal process. It was more labor intensive than we originally thought it would be, but now that we have a core process in place, we feel that it'll be easier moving forward. We do feel, though, that pre-survey preparation and education of everyone involved is really essential. There were less IT issues than we originally thought. Where we saw bigger issues was with hospital personnel not being as familiar with how to screen share, even though we had reviewed the process. And obviously, it's easier to navigate through documents yourself, whether they're paper or electronic. So having someone else do that was a bit cumbersome at times during the document review session. And one thing that we found was a little bit surprising was that some hospitals did not follow any social distancing. They wore masks, but they sat in a conference room shoulder to shoulder. And we weren't sure if it was because they work in close proximity in the ED on a regular basis. And so when they come together in a conference room, they continue to model that. But moving forward, we're going to emphasize the need for distancing and also the ability for hospital folks to remote in if that would help with that. They all did wear masks, though, so that was good. Moving forward, there's lots more organizations that are doing virtual surveys. I've learned a lot from the previous two speakers, and so there's lots of experience that's starting to be available that we can all tap into and learn from. We actually did the breakout sessions for these surveys kind of the hard way. We didn't use the formal breakout rooms that are available within the webinar platforms, but we plan to do that moving forward, which we think will make things a little bit easier. And I think it would be helpful as well to have some pre-filmed video of the emergency department and inpatient area, similar to what Carol just mentioned. We didn't do that, and we feel that that would help us to better capture a visual of the units. But all in all, we found that the process went well, and that's all. That pretty much concludes my presentation. I'm happy to answer any questions that there might be, but thanks again for the opportunity to present this information.
Well, Evelyn, as always, that was a stellar presentation, very, very informative. watching for some the questions come up in the box. Would it be possible for you to share your virtual survey training video or guidance document?
Sure, absolutely.
That, you know, folks that are on the call, if you think of questions after the session is concluded and you don't have access to the contact information for the speakers, we're always happy to facilitate those exchanges at the NASEMSO office. So again, you can email any of the staff members. Evelyn, does IDPH collect any fees for hospital surveys?
We do not. Not for the facility recognition. We've never had any fees associated with that.
I'm getting, again, great accolades for all the speakers and the appreciation for sharing that kind of information. As I've folks have been messaging me during the sessions. I don't think at the beginning of the year any of us could have imagined having to switch to virtual surveys and inspections and figure all this out. So having accomplished that in a very short amount of time and recognizing that things are evolving, our hats off to each and every one of you that are trying to make that happen. I have a question about when the recording and slides will be available. We're trying to, we're putting the PowerPoint presentations on the NASEMSO website as a PDF. And I think most of them should be uploaded now. As you can imagine, the files that we're creating as far as recording these sessions are massive. So till we get them edited and split up into separate sections, that's taking a little bit of time. Those should be available fairly soon. Thanks to Hannah, we now have a YouTube channel, and that's where we'll be sharing the videos. It'll make it a little bit easier. Recognizing that some states have blocks towards YouTube, we're looking at alternate means of sharing those videos as well. So are you seeing any more questions there on your end, Hannah? Anybody would like their microphone open to direct questions specifically to the speakers? Any final thoughts? Joe, Carol, Evelyn, again, thank you all for your wonderful presentations today. We really appreciate it.
Kathy, this is Joe. I just want to thank you for putting this all together. In this crazy world we're all living these days, these opportunities keep coming up, and this is a grand slam. So thank you for all the work you do every day supporting EMS and supporting this conference.
I appreciate those good wishes, Joe. Thank you. Okay, folks, that'll give you a little bit of a break, maybe to catch a bit of lunch. Don't forget to join us at 3 p.m. for the NEMSIS presentation. We saw a preview of the slides, lots of great information there to share with y'all. So have a good afternoon, and we'll talk to you in a few hours.